La- Ladies and gentlemen, a warm good afternoon. I welcome you all for the faculty's update on advancement in medical robotics and research interactive session. We are thrilled to have you all gathered here today to explore the cutting-edge advancements in the field of robotic surgery. This event promises to be an exciting platform for the exchange of knowledge and ideas, fostering collaboration among experts, researchers, and healthcare professionals. In this short discussion, we will delve into the latest developments, techniques, and the transformative impact of robotics in surgery. Together, we will pave the way for a future where surgical precision and patient care research reaches new heights. Thank you for being a part of this important event, and we look forward to an inspiring and enlightening experience. I once again extend my warm welcome to one and all present. For being the first speaker for this event, we would like to welcome Dr. Kesava, Head of Department, Cardiothoracic Vascular Surgery, PhD Super Specialty Hospital. We welcome you, sir.
Good afternoon to everyone. I am very happy and pleased to see a lot of young men in this field of medicine. This is something robotic, it's evolving in the current practice. In another decade, it will be well practiced like what you see today as a laparoscopic procedure in most of the abdominal entity, or laparoscopic procedure in thoracic entity. Today we have a very renowned robotic scientist, Dr.Kesava, and Dr. Peelamedu, is a senior consultant urologist and well specializing in robotic work as well as the research and development and for most of the robotic equipments. Today we are kind of thinking of robotic, is it necessary? My teacher, Dr. Peelamedu, is here. When I was doing my MS post-graduation, he is my teacher, and this last topic he started very small scale to just examine the abdomen. It's called diagnostic laparoscopy. Then we started doing adhesive lysis, a post-operative adhesive bowel symptom, obstructive symptom, adhesive lysis. Then on fine morning we have to do search for a needle lost into the abdomen. So that's a foreign body retrieval. These are the three procedures we did over a few months' time and we present in various forums, starting from Racecourse Surya Hotel to some other national and state level board. And that time I was once again a student of laparoscopic surgeon, Dr. C. Peelamedu. We used to hold the camera for a few hours and the whole procedure would go like that. From that levels we started, and we started like a AMASI, Associations of Minimal Access Surgeons of India. Sir probably remember it, the whole nation membership for that is less than 100. Today we take the laparoscopy from everybody is a surgeon, became a laparoscopic surgeon. Thousands. You see how this whole thing is transformed into a minimal access surgery. Those days there was a mixed response for a laparoscopy. I was in Coimbatore Medical College. We never had laparoscopic facilities at that time. And Dr. Peelamedu and Dr. Peelamedu was very keen to get some kind of instrument and all this thing. But the government that time was not very keen of investing on that because it's a very elusive area of practice. Why you should put 3 trocar or 2 trocar into the abdomen to take a small appendix out of the abdomen cavity. We can have a lance incision 1 centimeter, hold it, then take it. So there's a lot of mixed response. The same response for robotic surgery today we see in especially cardiac and thoracic surgery. The investment is high, the turnover of operation and the outcome is may not match with your investment if you are doing one specialized work. As a surgeon of this hospital, I was a general surgeon initially, now I became evolved into thoracic, cardiac, vascular, the whole spectrum, adult, all these things. I thought slowly we should update. If you are not expandable, you are expirable. I can't going on doing the same procedure. Then we thought of doing something, robot will be useful for the thorax. It was successful. Subsequently, we did cases, we are happy. The post-op recovery, the way they go out, all these things. The only limiting factor is the cost and the time we spend for that. If I want to open the chest midline and take a tiny tumor, hardly spend half an hour to 45 minutes. But if it's going to be a robotic, minimum it takes 3 to 5 hours, sometimes more than that. So that time frame on is the limiting factor for a busy operating room and the surgeon. You can't spend a whole day for a single ASC closure and a robotic operation. So these are the things we need to avoid, like what I mentioned, the laparoscopy in 3 decades ago, now it's become familiar. We started with appendicectomy, now we do whatever you name it, colectomy, liver section, liver transplantation, all these things is possible, nothing is impossible. We used to think, is it possible by a laparoscopy to do a Whipple's procedure, Whipple's operation? Oh, that can't be possible. Those days we used to think. Even if the examiner asks in Viva, you say clearly it's not possible. Now if you say it's not possible, you will be failed. Because everything is possible. So with that introduction, I will just move on to a few slides. We are already running short lectures, that's why we thought not to go for all formal invitation, formal talk. We will just enter into the subject, what we are and what our expectation. The robotic surgery, current and future perspective. What will advance this technology that we have to go to? If it's a PowerPoint projection is an issue, if it's a slide projection, you can always rotate manually and do it. Before that, we used to OHPC, very simple. Even if you play out of the thing, yeah, you can bring it up, back it, within a second you can project. When I was doing undergraduate, I would sit in front of that OHPC, it will be very warm. Then I will sit to one paper to another paper. It's easy for the lecturer to just go without any interruptions. Yeah, like you got this you see this, this particular thing we presented the presence of Kesava and our Dr. Vinod is a professor and head robotic and automation of PhD Institute of Technology. We presented this. So this is the thing actually over a month time where we did thoracic sympathectomy, diaphragmatic repair, upper lobe trisegmentectomy, thymoma excision for myasthenia. The myasthenia timing fixation, minimal access, robotic is very fast recovery because there is no big thoracotomy. The recovery from this anesthesia, drugs, all these things is very good for a myasthenia patient. So you should choose this procedure even if it is going to add some extra cost, those going to deserve in a post-operative recovery. Next one. This is just a nostalgia, memoirs. And this one, on the day of our presentation, is actually supposed to be an international conclave on robotic work. And this was the thing is established for a robotic exhibit which is displaying some of the utility of robot in different areas, including aerospace and security guard, all these things. It was a good time, we just we get excited to see all these things. The gentleman behind this is Mr. Arjun in the front. Behind this, Dr. Krishnamurthy Raman. He is a Bangalore, he is doing a lot of work on data science as well as artificial intelligence and robotics. Why we need to know all these people? There are 4 runners to just give a platform for us to take this science and the technology to a height, so that we can utilize. So we have highly linked with so many people, and the man with mask is, I think, is Dr.Kesava. At that time, actually, we are recovering from the COVID. And SAR is associated with us during COVID by kind of Zoom meet. We had a RITS program, Research Innovation in Cardiovascular Science Device Manufacturing, was kind of actively participated on those online programs also. Thank you, sir, for that. This is the kind of thing we should take as a message. Now I'm going to constrain myself to our specialty where it has wide scope because we have heart lung and our operation room list is much more than any other list considering the heart and lung, and it can be converted into a minimal access from there to a robotic. Predictable outcome, if something is not good for us, you can straight away open. Instead of putting hole, you can just make all the hole into incision and you can access to the heart and you can conduct the same way what we do. Because in a cardiac surgery, we need to control the heart by extracorporeal circulation, cardiac bypass. That will be already on. Only the way we approach, either we approach through the midline sternotomy or the minimal thoracotomy or part of this robotic pore, that's the difference. Once you are not happy, something is going out of our control, we can always open the chest, control the heart. So that's a big advantage of this thing, and outcome is most of the time is predictable. You see the learning curve, if you talk about the learning curve, if you already operate over 10 years, 15 years, 20 years, 25 years, you handle thousands of heart, there is no big curve required to handle this instrument because Robo is going to do a lot of wonder by endurance movements. The eye-hand coordination and your ergonomics is not like our laparoscopic or thoracoscopic surgery. Once you sit on the console, you feel that you are playing with a joystick with a video game. And somebody is educated through now the new generation of people, they become graduate like you people, you will much more better than any of us because you are already oriented to the joystick and the video game, you can make wonder in the robotic console. And the conversion is safe and it warrants. So ultimately, recently we had one meet at our direct office, how to improve the number, how to make more productivity out of that investment. All this is actually a real question we should ask ourselves. A single surgeon in a single center investing for a robotic may not be very fruitful in the initial period because the number is the game. You need to generate a lot of numbers to get the renovation, and there are things we will have recurrent cost on robotic utility, and this all is not in our hand. The administration and the management part, we should make this balancing between the investment and the income what we generate out of the robotic procedure. So we have some idea to this. We should do a more number, then to minimize your time. You can utilize the operation room with a short time without much of expenditure on single case, and everybody will accept. Once you go in and bring the case in 3 hours, the people will feel good. Every day you go in 8 o'clock and come back by 8 p.m., then nobody will accept. Especially the supportive staff will get really tired, and they will discuss differently. Why not just walk on and do 2 hours to finish and go during the Diwali time? All these things, you can't just hold somebody for doing with Robo. So that part is very important. If you want to have more acceptance, we should have more number and short time of spending on work, and team will mature and handle these difficult situations. How to improve the number? The best thing for us, we have some contact, patient referral. They won't come to you by taking a wall repair or replacement robotic or AI situation by robotic. They come for either minimal access or conventional. They want to live, they want to have safety on their life. In a cardiac surgery, there is no big osmosis. Scar actually severe time. They won't actually bother. If you say, then we convert it, first so that kind of understanding, our people is very keen. They won't come for a robotic in the first instant. You make hundreds of numbers, then they will go, they propagate, they will say, I am safe, you will be also safe, there is no big scar here. And all these things should be given by the patient as the ambassador, as propaganda. You can't make yourself jumping that I am doing this and you please come. That nobody will come because they will actually panic about the thing. Why not the routine conventional operation rather than some machine is operating inside? The other perception, they always feel that you are not there, the Robo will operate. Like Robo serving in the hotel, Robo serving in some other area. That is not the case. It's completely your heart, your mind, your thing is operating. The endurance is helping you to manipulate the things and make it better. So this actually assisted robotic like laparoscopic assistectomy. If you are not very keen on completing it, you just put all the arms inside, operate and just complete with robotic assisted. At least one light will be given by the robotic arm. Initially, way back 20 years back, SR Hospital, A-class heart hospital in Delhi, they do robotic mammary dissection, only used for robotic. There we see single this thing, only it will do the mammary dissection. Rest of the things, the surgeon will do a conventional or a thoracotomy procedure. That's long back. Now Robo can complete the whole operation, especially wall repair, replacement, ASC, VSC closure, but multi-vessel CABG not very comfortably completed by robotic alone. And if you try to do all this specialty, now in our hospital we do all this cardiac, neuro, pediatric, gynec, onco, all this you combine, you can make a better number, better listing, and you should put a better outcome. affordable and attractive package you should be considered in compared with your minimal access surgery. Then people won't think kind of higher on the operating cost. If you do a CAB, valve replacement or repair by 3 lakhs rupees, if you add another 1 lakh, they won't mind. But if you add another 3 lakh, they see it's a twice of the package. That we should consider. If you do a mixed multi-specialty work, then you can minimize the overall expenditure on the overall with robotic, disposable as well as the instrument. The hybrid robotics, if you are really evolved, you can do one through the cath lab intervention, another one through the robotic. All this is quite possible. So this is probably the finishing this thing. The future of robotic surgery, what will be? See, for us, another 10 years we will be old enough. Once you reach 60, people will say that over 60, what is new advancement you are going to do? But the 50 to 60 or the 50 to 70, sometimes you make some change, you can reach the milestone what you really expect. The growth will be steady and sustainable because, as I mentioned, the initial opening, laparoscopy 3 decades back, it's different. Now, if you say different, nobody will accept. There is no mixed response to that. It's a standardization for colectomy, for laparoscopic use of ectomy. All these things quite possible, and the recovery is time tested. On multi-specialty utility, now the specialty like ENT, orthopedics, and skull-based surgery, all is into the robotics. In another 10 years, everywhere you have a robo machine because it's going to be more familiarized, and our Aishwarya is our product. Please Aishwarya, the student should see. He is our product, now he is into the robotic kind of manufacturing unit and designing all these things, what we call the research and development. She can bring a lot of affordable instruments and everywhere it can be used in the like a concept of Make in India. That's a great opportunity because you have technology skill, but an instrument, if it's a limiting factor, you can't execute it in a big number. Solid organ transplantation, that I was discussing, our vision, our urologist was telling, there are centers in Kochi harvesting their kidney by robotic. But I'm sure that Ramalingam is already doing it very simply and a very expanded way. And I used to assist him because we are associated for almost 2 decades on renal transplant. I just handle the artery and vein, he do the laparoscopic dissection. Now probably is doing robotic in the center. So that's quite possible. If it's going to be in a renal, next level it will ascend to other area like hepatic, segmental dissection, anastomosis, all these things is quite possible. If the number goes up, the cost will come down. You can always say that you are doing 3 cases in a day, you cut down 50,000 in every case. The management easily accept. You do 1 case in 1 month, then you can't have anything different to cut down the cost. So number is the game. It will be one of the essential establishments most of the healthcare centers. Now in Tamil Nadu, the government of Tamil Nadu established a big advanced robotic center in Coimbatore Hospital, Chennai. So another version will come in every district hospital, at least the teaching hospital. It will be a countable number in most of the government sector. Inseparable skill for surgeon, it will be must like what you learn laparoscopy. When I was doing my MS general surgery, there is no big opportunity to learn laparoscopy. You can only handle the light or assist the surgeon. But nowadays, the basic, most of the MS general surgery, they don't know how to open an abdomen for a appendectomy. That's a great loss. See, the only operation we learn throughout our MS post-graduation, appendectomy, thyroidectomy, additional hernia. Rest of the thing is on the way. We collect blood, sometimes we close the wound, sometimes we re-explore and we sleep. So these 3 operations only made us to become a surgeon. The appendectomy, thyroidectomy and hernia repair. Now there is no such opportunity. You can't take a scalp and insert the abdomen in a long way. You have to only work with the proper and cannula. So that's actually a missing area of your skill learning. But it's good for scientific jamming therapy, robotic surgery. Because your eye-hand coordination is already there, you can just evolve into full-fledged robotic surgeon for a complex procedure. Now, the great opportunity, see the whole idea of today, what the rest of the kind of speaker is going to talk about is the research, innovation, robotic, automation and AI sciences. Will improve the collaboration. See, another area we can bridge once you are a robotic surgeon into the technological people like automation, AI specialists and the engineering side, and that will be a big boon for you. Throughout work, you can just shine your skill and your knowledge to the different skills. engineering science and medical science, once they fuse, they can do wonder in manufacturing all these things and we can make it. So this is our whole idea. We established the RICS program on behalf of our Abdul Kalam sir. So Make in India vision, technological transformation of your science into devices. See, that's a big lack in India. So we purchase all these things from other countries for valve, for so many things. But the time-tested valve we have, one is a TTK Chitra, is Indian made. So that's actually it's a big thing. Over 3 decades we have used thousands of valve, is Indian made and it's a very, very stable structure or the device to use in a life-saving operation, the valve replacement surgery. This is just, see, we are not only advancing our skill and the procedure, we want to educate our local community. Unless they know what is robo, how it's going to really work, all these things, they won't come for a procedure. We should always educate the people in a regional language. We tried this and we conducted one kind of a conference, and this was the book we launched on this particular day. Yendira Nun Tuvaravali Ninjala Arusikche, Robotic Thoracic Surgery. Ninjala Robot. Once you see this picture, all these things, they go back to the robo, Yendira. So the Rajini movie. So all these things is almost similar, they get excited. Something is like this is going to operate, all these things. And you should not mix with other movies, such as the Malayalam, the Android Pujapam. Once they see this and this, they will get confused. The robot is really life-saving or safe. So this one is the book, it's going to deal all the terminology of robotics in Tamil. I really tried my best to put this content into the Tamil language without any change. There will be a car to become fair, the robotic things. All these things, so you should read somebody's interest in Tamil and into the science, you can enjoy that conversion of the medical science term. So with this, I thought I should call the next speaker. Before that, Dr. Ramalingam will introduce our invited special guest, Dr.Kesava. Dr. Ramalingam, please. Thank you very much for patient hearing. Thank you.
Thank you for the informative session, sir. Next up, we have an eminent personality among us. Now I would like to welcome Dr. M. Ramalingam to speak upon the topic Research in Potential in Robotic Urology.
Respected Dr.Kesava, dear friends, Vinod, Dr. Murugesan, my colleagues, dear students, and ladies and gentlemen. I have a great pleasure in participating in this symposium on robotics. It's all possible because of our friend Dr.Kesava's consented to be here. In spite of his busy schedule, he came just for 1 week and he is still available for us to discuss and ignite some young minds right here who can take the research into different levels. So I chose the topic of research potential in urology. Most of the things are not existing right now. But I wanted to Kesava to either comment upon and see whether how far he can guide us and correct us and take these things forward. So 30 years ago, we all started the laparoscopy. It's all struggle. You have only single chip camera, and you have to do everything on your own. you don't have any help, you don't have an experienced assistant. So doing the laparoscopy for the first time in this part of the India, and only 5 of us started in 91. And it was very difficult to convince the colleagues, other medical fraternity people, and public. So it was quite difficult for us for the first 10 years. And then second 10 years, when we became comfortable in doing all the procedures possible, right from laparoscopic nephrectomy, radical prostatectomy, cystectomy, everything, then the robo came in. So from 2000 onwards, the robo came in, and then you can see the comfort one can get. You just sit in the console, you have either an immersion type of vision or the open console vision of other companies. So it gives comfort to the surgeon for sure. And if a lot of surgeries are done, at least about 100 cases are done by the robotic surgeon, then the patient is also benefited, because the time taken for the surgery to be finished is faster than the laparoscopy, blood loss is less, and then you have all the comforts of endo wrist. You have something like you have the wrist inside the body, so you can manipulate 7 degrees of freedom. So it gives a precision. You have a 3D vision. You have wristed 7 degree freedom movement. That's how the robotic arms move inside. But it is not without a few disadvantages. Many advantages. The disadvantage is that you don't have haptic. And halfway through, if you really want to change your port, there is no provision for you to change the port. But overall, over the last 10-15 years, we have progressed very much in the robotic field, and about 20 or more companies have attempted to make robo all over the world, and India is not too far behind. A team of doctors and technologists in Delhi were able to make the robot in India. It's called SSI, and this is how it works. It's an open console with a 3D vision, quite comfortable. And you can see the robotic radical prostatectomy done by the SSI. It is almost as good as the time-tested monopoly Da Vinci. So you have the freedom of movement of the instruments, 3D vision, and fairly fast compared to the open surgery. So we have advanced this far, but what is next in the future? We have a single port robotic system. You have a 25 millimeter incision in the belly button. You can put in a single port, and through which the telescope can come in, and 3 arms can come in. So that way, with a single hole, if you have a radical prostatectomy, you do with a single incision and take the specimen through that. That's it. It's going to be very expensive, 3 times more expensive than the conventional robot. We were able to bring in the hemostatic mechanisms in the form of diathermy or vessel sealing and stapling. All these things have happened, but is there anything more for the future? Yes, we need to improve upon the haptics. We need to make the camera better and better. I will show you with illustrations of why you need the camera. And then we have pundits like Dr.Kesava, the world-renowned authority on artificial intelligence, how it can be coupled with the existing robotic. And can we get some mentoring or signals from the using the AI that we are very close to an area, blood vessel, you don't cut it, it has to give some signals. Whether we can get a hint whether you are going through the tumor or you are going through the normal tissue. And the next one is, can we do PCNL with the help of robo with a precision Now we take a lot of time to do punctures. Also, can we get the nanotechnology using genomics to treat the metastatic tumors? Now we give chemotherapy, all the organs are affected. But if it is a nano-based, genomic-based robotic technology, then probably we can treat the cancers much better way. Coming to each one area where I wanted that the research can go further, haptics has happened successfully in a larger picture, but this needs to be miniaturized. I will illustrate with an example. Now I am doing a lymph node dissection. You just see there, you are not seeing where the scissor is, what exactly is happening, you don't know. Suddenly there is a bleeding. So we don't have haptic to know what amount of pressure I have exerted. And I am not able to see from my left side whether the movement I made is the right one or is it too much. This is a child when I was doing a robotic pyroplasty. You don't know whether you are tightening too much or is it loose. If it is tightening too much, it can end up in necrosis of the tissue. If it is too loose, the urine will leak. So we need to know the haptic. I'm going to illustrate with one more situation. You see here, if only the telescope or camera has come from my left side to show the tip of the scissor, I could have probably stopped at a level where I am going to injure some smaller branch. Yeah, tributary might have come there, but I really could not see where exactly was the bleeding. It's only by a trial and error I am taking a bite. I am not seeing where I am exactly taking the bite. So this way the camera has to be improved and we can do a better thing. Another area where you are doing a nephrectomy in a case, you just see there, the tip of the scissor is moving and you don't know where is the scissor exactly cutting. See, in this movement, the duodenum might have been injured, we don't know. If some signal can come that you are very close to duodenum, using either artificial intelligence or so, if you know you are very close to duodenum, then I probably will not do that movement that fast. This is another situation where if you see there is a tumor well within the kidney. It's all well within the kidney. You need to cut the tumor all around. When you go underneath, you can rotate the arm, but you are not seeing what exactly is happening. So we need to get some augmentation reality or some signal. In the last picture you can see that you are very close to the tissue or you are going through the tumor or you are raising so much of normal tissue. If you get a signal, if you set up a target that tell me within 1 millimeter away from the tumor I need to cut. If such signal comes, probably I will do the best for the patient. We are doing a good job, and we do a better job. So this is another area. We have a cancer in the kidney. We remove the tumor, but we have a small tumor in the liver. Generally what we do is we give chemotherapy. So the chemotherapy is not without deleterious effect on the normal organs. So you can get anemia, you can get multiple episodes of infection. But if by combining the genomics with the nanorobots, probably using the antigen-antibody, monoclonal antibody reaction, we can specifically attack or destroy the metastasis. So that's one area of interest in the future. The research is on, but we need to really wait and watch whether it is going to be successful or not. So that way, we can treat the cancers in a better way. So this is what I told that you are doing laparoscopic cytocolpopexy you wanted to fix that mesh somewhere, the robotic arm was not able to really retract the sigmoid column. It was not able to do that. All the time it is slipping. So what exactly I wanted is to change the arm, third arm. I need to undock and then do it, which will take about 15 minutes. By then the position, everything will change. So if there is a mechanism by which you can just change the arm direction, that will be better. So that's one area is potential for research. So nowadays there are about 5,000 urologists in India. 500 people are doing laparoscopy. 50 people are doing robotic surgery. Only 5 people are able to do the vascular anastomosis comfortably. It's okay for us, we can do, but we want it to be reproduced. Everybody has to learn and do it. Then only as a nation, as an association, we progress. Our medical fraternity, younger generation will become more experienced and knowledgeable. So what we need is the training methodology. This is what Dr. Aishwarya is going to touch upon, telerobotic surgery, so I'm not going to touch upon that one. So what are the research that are underway in at the moment? At the moment in urology, so there are areas in the kidney where you cannot reach with the available instruments to break the stones. It's called flexible ureteroscopy. But if we have a robot, and if it can reach the inaccessible areas, then we can use the laser and cover the stone. So there's going to be an advantage. The trials are going on. The next one is percutaneous nephrostomy and lithotripsy. This is research being undertaken in Malaysian group of people where the image of the fluoroscopy is taken in different angles and it automatically fuses them, and then you are able to puncture dart on the area where you really want to puncture. So that is the robot-assisted PCNL. There is another company called Monarch of Ethica, which is also doing the research. You can see the direction in which the needle can go. If all the information is fed into the robot, it can decide where exactly you need to puncture. So what, we have been talking so much. So what are you doing by yourself? So we are trying, at the moment, what we do is we use the ultrasound to know the depth of the tissue of interest, maybe stone in the kidney, and use the fluoroscopy to get the other dimension. One gives the depth, the other one gives the anterior-posterior orientation. So you try to puncture, and then it is only a trial and error. On average, we make about 3 or 4 punctures to make a perfect puncture. So we lack time, we get more radiation, and then there is a lot of blood loss. So how can we prevent that? If only we have a robot that can really make a perfect puncture, then we will be able to save time, save blood loss, and reduce radiation. We have a team collaborating with Dr. Arjun and team. We have taken up that project. Quite a number of meetings have happened, and hope in a year or so we'll be able to give you more useful information. My passion is training. What I told is that we need to educate our younger generation in a better way. So it all has to start with a simulator first, and then go on to the real tissue. This is my passion, and I started my research with Dr. Arun sitting right here in Wales University, and then collaborated with Dr. Vinod and team, and along with IIT, PRICAL, LND, you named quite a number of, and we went to South Korea, and we made some progress. Honestly, we are not perfected it. So that's still a lingering feel in our heart of heart that we have to make it a successful one. That's where PhD Tech, myself and L&D are receiving one of the best projects in 2021 or so. So I told that the ideal thing is to train the people in the real tissues. So what I was contemplating so far was a simulator. But if you have a simulation which is upgraded into a real-time tissue dissection, that gives a real haptics. And we have been conducting this animal lab training for the last 25 years. We have trained about 350 doctors, neurologists, and people from UK and other countries. We do the animal lab training, tissue dissection, and live cases. And this is our animal lab here. We have this privilege, we can train our younger generation better, and that is the animal lab training. But that's all very expensive, and we can't get it for everyone. So what we need in this need of hour is the innovation of Dr.Kesava's robotic simulator. This is actually ROS2. The first model was ROS1. This is ROS2, wherein a lot of programs are embedded, and you can get into any of the program and then feel like really doing the surgery. So the master manipulation has been perfected. This is perfect, but you need to get a feel of the tissue dissection. That will be our project for the next year. So this is what my dream is. This is what how I train the urologists, like vesicular anastomosis. You take any inanimate tissues, and then all that you need is to really do a precise job and understand the movement, 70-degree freedom movement of the instruments. And this we are right now giving to quite a few people in our setup, but it should be available for most of the people in the future. So the future is in your hands, the younger generation. We have tried hard to do something, and the healthcare technology should be available, and it should be affordable, and it should be reproducible. So only with the simulation, number of people, thousands of people can get exposed. Then you land up in the real tissue models. So we have started the journey. We have helping hands from so many places, from US, from Bangalore, and the PhD family, and I'm very grateful to them that we are able to join with them. If you are able to handle something, do some research, sitting here on the moon, is it too difficult for you to do with the available rover right in front of you? So we can take up a lot of projects. This is only a little tip of iceberg which I have shown it, and probably Dr. Sage will tell you more and more. And if you have any queries, maybe after Dr. Sage's presentation, we can answer together. So thank you very much, all of you, for listening.
Thank you for the enlightening session, sir. Next up, I would like to request Dr. Ramalingam to introduce the keynote speaker of this event, Dr. Kesava, Vice President, Research and Economic Development, University of Albany, State University of New York, USA.
I have a great pleasure in introducing my sort of virtual mentor. That's how I will say, and a friend in need and a friend all the time, accessible and in communication. That we have to, he is a person who thinks that we have to give it back to our country. So in a nutshell, what I can say is, he is an innovator, a true academician, and a true researcher. This combination does not happen quite often. Once in a blue moon, it happens. And we have a friend very close to us, and he has innovated so many things. For the first time, this virtual simulator. and he has been awarded many awards for innovating artificial intelligence related researches, and at the moment he is the Vice President of Research and Economic Development at the University of Albany, State University of New York. And he has published lots of articles on artificial intelligence and automation. And we are here to listen to you. Then if I need to really complete the CD, it will take about 15 minutes. Then we will miss 15 minutes of Dr. Kesava's talk. So we would like to listen to you, and we will know about you in person. Thank you.
Could everybody smile, please? This is my hobby. We are watching, and I also want to see who I'm speaking.
Thank you, Dr. Ramalingam. Well, it's very difficult to do a presentation like what Dr. Ramalingam did just now. All the cases and examples. So first, let me just clarify that I'm not a doctor. I pretend to be one, but I'm an engineer. Different kind of doctor. But I'll say that what really drives me is innovation. And I think that, if you walk into an operating room today, everything you see there, some engineer has worked in the back at some point in time, right? So on behalf of all those engineers, I'm standing here to just talk about what we do here. And so I'm going to talk about robotic surgery from my perspective, as someone who develops these kind of products, but I also will borrow on some of the things you heard Dr. Albany mention about challenges in robotic surgery. So just a disclosure. So what I'll do is I'll talk about medical robotics as the way I see it, some challenges and opportunities. When I talk about opportunities, I'll talk about some of the things that is happening in my lab or other labs in the places that I know about. So let me just start by saying how important everyone thinks robotic surgery is, right? Dr. Ramani showed the last slide about, Chandrayaan mission going to the moon. In fact, there is an equivalent of that happening in medicine as well. Today, robotics and AI, the combination of that, all of you youngsters here, you will be using it and it will be part of your life in the future. There's no doubt about it. All of you know about this, right? So it is important what you're listening in this lecture. Maybe years from now, you will say that there are 2 hours in a Saturday afternoon, which you should be studying for exam or test. You listen. It might actually really help you because you're going to see this one way or the other. What this slide shows that if you look at the opportunity for AI in healthcare, the number one opportunity is robotic assisted surgery. What I'm saying is that AI will have a tremendous impact in how we treat people. And we saw one example of robotic surgery, but I will try to show many other examples as well. So the field of medical robotics is very broad. If you look at image-guided robotics, there are a lot of applications in surgical telerobotics. Everything we've heard today is in the minimally invasive surgery at the bottom, but there are many other robotics. I will talk about that. But there's also robotics in other areas, like rehabilitation for helping people who are completely paraplegic stand up and walk. So the field of robotics in medicine is very broad, right? We are seeing a small segment, and the reason I'm saying that is based on what area of healthcare you specialize, you will see some or the robotics helping you or being a part of your treatment. And this has been noticed by companies around the world. What this slide shows is that if you look at the human body from head to toe, there are about 130, 140 companies that is working on a robot for some part of the human body, head to toe, right? So I listed some of the names. If you just take the knee replacement, there's Mako, Smith & Nephew, bunch of companies that FDA approved is already out there, and there are many other companies who's already working in some of the other areas. I will just run through a few of them in the next few slides. So most common one which you hear, you've heard a lot about that, so I'm not going to really expand, but it really all started with laparoscopic surgery many years back. And the first company that came up with the product was called Zeus System. It was a company called Computer Motion. They came up with something called Robotic. The Robotic is in a museum in Washington, D.C. today. Because it did not succeed, like many technologies, it came way too early, right? So, however, Computer Motion and Intuitive Surgicals came about 5-10 years later, and they captured the field market, and then Intuitive went and acquired Computer Motion. In fact, Computer Motion's robots on the right-hand side, they are in some people think it was better than Intuitive. But business is business. Intuitive bought the other company and shut down the robot. So for many years, at least 15 years, there was only one really good robot in the market, and that is Da Vinci. So you saw many cases with Da Vinci. What actually happens in Da Vinci is that the surgeon is sitting in a console and the robot is somewhere else. Originally, when this technology was developed, it was developed by US Defense funded this project because they wanted to treat soldiers who are injured in the battlefield. So that was the idea. However, this never actually got used in the war front, but it became a regular robot. So it is interesting that even today, the surgeon and the robot are two. They usually sit inside the same room most of the time. Technically, they can be in two different cities, but today the internet is still not very stable, reliable. So most of the time, like in the US and most of the world, FDA has not approved doctor and the robot in two different cities. Technically, it's possible. You have a lot of cases, but if you really look at it, most common cases today is urology on the right-hand side and gynecology on the left-hand side are the two most. In terms of urology, in the US, 90% of all prostatectomy happens in robot today. And in terms of hysterectomy, almost 70%. That's about 350,000 cases happen on a robot. So this is a mainstream thing in US, and it's catching up. You heard some numbers in India as well, and it's going to be catch up. I will also mention other fields unrelated to urology. As an example, Mazor X. It actually fuses images, and the robot on the right-hand side is used for spinal surgery, for cannulation and for stenting in spine. And what it does is it takes 3D images and it helps the surgeon to align very precisely to hit between different vertebral sections. So that is this is again an FDA-approved product. Smith & Nephew's handheld robotic system. This is used for knee replacement, for helping polish the knee before the implant is done. And what this actually does is it scans the knee, and as the surgeon is grinding the knee, it actually stops you from going where you should not be going. So it really helps in getting much more precise machining. Then there are other robots, like for example, Flex robot system. This is really designed to go inside the mouth. It's like a tube. Unfortunately, it's not commercially available. There's even one for robotic hair transplant. So not for robots, we know that. There's one Indian-made robot that you saw a picture that Dr. Raman showed. A mantra which can have 3 arms or up to 5 arms. Hopefully, this robot could go to the other countries and compete with Da Vinci and have it made in India. Make everyone in India proud that there is a robot from India is making ends. You also heard about a single port robot. The advantage of single port is that you don't have to make multiple trocar insertion. And this is FDA approved again, and there are some examples like nephrectomy and others where the space operation is very small, and so single port is especially successful in those kind of operations. And there is also for thoracic and also for lungs. For lung cancer, there are some really good applications as well. Again, another very known areas or nodes, natural orifice transluminal endoscopic surgery. The nodes is kind of surgery used for doing lower intestine and things like that. Again, commercially, this is I will not say that this has widespread application. Nevertheless, this is again another example of a robot. So why robotics? You heard a lot about the things you can do with robot. Precision and control during surgery is definitely one area. It helps surgeons to do more complex surgery, access to remote sites, and also ability to interact or integrate sensors, imaging, AI, and all of this you can do with the robot that is not easily done in laparoscopic surgery or open surgery. But there are also some other interesting things why hospitals like investing. One of them is that there are a lot of studies which show that after robotic surgery, the patient can go home very quickly. In open surgery, people stay longer. There are more expense to keep a patient in the hospital. So lower stay in hospital is cut down the cost, and also patient's recovery is faster. Some studies have also shown that conversion from laparoscopic to open is higher than robotics to open. So conversion is again another interesting reason. Okay, and again, there are some studies that have shown that long-term outcome is better for robotic surgery, even though this has not been studied for all robotic surgery, but for prostate, thoracic, and a couple of them I've seen, they've seen that 2-year outcomes are better. So there are many reasons. However, if you look at robotic surgery, moving from open to robotic surgery is very complicated, but moving from laparoscopic to robotic surgery also has its own challenges. If you ask me the kind of challenge, it would be like, if you know how to drive with gears and then suddenly you sit in a car which is very different, you take some time to learn, right? But going from open source to robotic surgery is, you know how to do a bicycle, but then all of a sudden you're given a Ferrari. That's a big difference. Okay? There are also issues, there are things you do in robotic surgery which is not traditional surgery you think of, and mental load in surgery is supposed to be higher in robotic surgery because you are disconnected from the patient. Unlike open surgery, laparoscopy, where you're right in front of the patient, here you're disconnected and you are actually using monitor and technology to monitor the patient. So there is a lot more things going on inside the operating room in a robotic surgery than in other surgical things, right? And that's why there's a lot of opportunity for people like me, who work in engineering. It's an exciting area. For many years, it is going to be very exciting because, like I said, AI, simulation, all of these things are bread and butter of what we do in a surgery. So I'll give you some example. I mentioned that robotic surgery, in fact, even laparoscopic surgery as well, you can use technologies to make surgery more reliable. One example is this thing called Firefly, which is integrated in robotic surgery. It uses near-infrared light. So what it does is it highlights, the cancerous tissues and even blood vessels and things like that, which you cannot see with naked eye. So while doing surgery, you can actually put the light on, and it improves the margin of surgery. So here's one example of how integrating imaging can make surgery better. Now this technology itself is also available for laparoscopic surgery, but what robotic surgery allows you to do is that it's already integrated into the system, so you can actually improve the quality of the surgery. This approach of adding imaging is actually being expanded to many other cases, like in case of lung cancer. They have shown that you can improve the resection of tumor much higher than without having infrared light being put on that. And this is a paper from New England Journal that was published about 4 or 5 years. that looked like 60 or 70 patient cases. We have also in our lab tried to use AI to understand what is happening in surgery. So our approach was to actually look at the tool being moved using the camera, and then using real-time analysis of what is happening to the tool, and using that predict what kind of surgery is happening. Like for example, we can look at the video and say if there is a suturing happening or tissue cutting is happening. It's the first step. The idea is that if you can predict what is happening, then you can also tell this robot in the future to go and do the suturing. So you may simply show you where you want the suture, press a button, and the robot will go and finish the suturing. Okay? Is it possible? Well, it's not there yet, but there is no reason why some of the more complicated steps in surgery cannot be converted automatically. Now let me give you a few more examples, very concrete examples of how AI can really make a difference in robotic surgery. And one of them, which my lab has worked almost 10 years right now, is looking at needle biopsy. So one, as everyone who's in medical field, you understand that biopsy itself is very challenging, especially a biopsy for breast cancer. If the needle biopsy is not done correctly, then you're going to have wrong results, right? So we were trying to see if we can actually use a robot to do more precise characterization or get the right tissue during the biopsy. Now, the challenge is not putting the needle itself. The challenge is to understand if the needle has hit the tumor or not, right? Because you're looking at the ultrasound, and if you're not hit the tumor and get the tissue out, you might get false negative. So we spent a lot of time looking at this technology. So this is a very early stage of what we build, where we can actually integrate an ultrasound with a robot, and then using that image which comes out, we can put a needle and align the needle, and if it hits a tumor, we can find out. So this is a very early effect of looking at whether we can recognize tissue, changes in the tissue properties or not. But we have actually expanded this work, and now we have built a regular robot. What the robot can do is, you can automate it. So you can tell the location, and the robot will align itself, it will go inside, and then as it goes inside, you have to understand how the tissue can hit, which tissue to hit. So this is where AI comes in. So this is the work of one of my current students, Feng, who is actually going to finish his PhD later this week. He spent a lot of time taking big tissues and inserting needles using this robot, and then creating a very large data and creating a machine learning algorithm so that it can recognize automatically what tissue it is, and more important, when you change the tissue. Like for example, if you move tissue from a healthy tissue to a tumor, that change in the property of the tissue, this AI can recognize. So that's what the work was going to be done. But our goal is actually more ambitious. Eventually our goal is to connect two different technologies into one. So one of my colleagues with whom I work a lot, Dr. Bhargav, he works on virtual histopathology, and what he does is he uses spectroscopic imaging, and then he creates a histopathology, and using machine learning, he can actually recognize, benign, malignant tissues without actually having to put it under a microscope, right? So he has a technology, it's 99.9% accurate. Now the question is, can we put this inside the needle for biopsy? So this is where we are working on right now. So our goal is that the needle itself will be having a fiber inside, and so once it goes inside the breast and hits the tumor, that's the first step. The second step, it will go in a helical shape and take a bunch of tissues, and then by the time the tissue has been, the data has been taken, on the computer to tell you whether it's malignant or benign. And if you can do that during the needle biopsy, then you don't have to take a tissue, send it to the lab, weigh it, and things like that. You can also do other things like, for example, test to make sure that the margins are correct, whether you have taken out all the tumor and things like that. So it can completely change the way surgery is done, and it could be integrated into traditional robotic surgery, so the surgeon can, anytime they want, they can just go and check to make sure that the tissue is malignant or not. So this is the technology, like I said, it has a bunch of stuff. It's some force sensor that can measure the force. It has an actuator which has a helical rotation, so it'll actually go rotating inside the tissue, the body, and things like that. So I will jump this, I will show you, and you can also align the robot by hand. So if you don't want to automate it, it's a semi-automation way where you can move the robot and just in part of the body where you want to do the needle biopsy and press a button, then AI takes over at that point. And this sort of stuff which some of my engineering students might understand, but I'll skip those. So a quick video, this shows the robot in action. So this is an automated mode and it knows where it's supposed to go. It's locating the position and then it finds out where it's supposed to go. And then it goes and inserts inside the tissue. It has taken the data, it puts it out, and then it does a safe retraction so that it does not hurt anybody else. So let me keep going. So these are the steps in a needle biopsy. The graph, if you look at it, the pre-puncture phase where you push and then the puncture happens and the skin is broken, then it goes inside and then the force is released, then it goes inside the tumor. So this is traditional data that has been collected by several people, and one of them is Coimbatore, who's a professor at Stanford. She's done a lot of work on that. So we have taken that and we converted an AI system where this data is taken and then it trains an AI, a system that can automatically tell you, it can classify different textures, and then it can give you in real time data that can feed into the robot, so the robot can stop or keep moving based on the tissue. So again, on the top you see the force displacement curve and a needle inserted. Bottom is actually a classification curve that an AI can do, and the peaks that you see is aligned with the peak that you see when the tissue moves from one to another. So the beauty about this is that in mathematical terms, we have technologies using AI that we can do that. It doesn't mean that it's ready to be used in a surgery. There are many more steps before we can take this and convert that. But I want to show you where this technology is moving. And this data just shows how accurate our system is. We have tested many different AI algorithms. The one we are using called Transformer is about 95% accurate. Again, we want to take this technology and put in other ideas too. Like for example, one of the ideas we have is to put this whole needle biopsy system in a handheld cartridge that can be used to do any biopsy, maybe head and neck or anywhere you want. And you press a button, it go and punch it, give you the data and send you out, so the biopsy can be done real time, on the spot, in situ biopsy can be done. Let me quickly move now and talk a little bit about human factors in robotics. It's another topic of my favorite topic. You heard Dr. Ramani say that that training is very important. So let me just talk a little bit about this. Yes, sure. So for almost in 2004, when Da Vinci was very new, we spent a lot of time trying to understand how we can train on robotic surgery. So at that time, I worked with a doctor, his name is Dr. Guru, in Buffalo, New York, where he was working on very early adopters of surgery. And that's when we realized that there's really no training system other than using animals or training on human beings. So we actually built a virtual robot. And using this virtual robot, you can actually train to do all the steps that is required to do surgery. We built models, like for example, mathematically we created training models that can be used for suturing, everything using computers, without actually having to touch the patient. And about 48 different modules which teach everything, how to use this fourth arm, how to handle a needle, how to tie a knot, how to cut a tissue. So everything can be done in a virtual environment so that no animals are hurt or this training doesn't happen on human beings. So this is the very first version of that. As you see, that this training system is very similar to Da Vinci, and Dr. Ramani actually showed the later version of this, which was much more smaller and lighter, but it actually matches every step that Da Vinci has. The concept here was that in flight simulators, they make a cockpit which is exactly matches the cockpit of the aircraft you're learning how to fly, but can you do the same thing using in the robotic surgery. So that was a constant. So very early stages of the robot being used. This video was taken at Mayo Clinic when we were doing one of the very first urology classes using training. And in long term, my hope is that a system like this could be used to validate if a surgeon has the skill to do robotic surgery. And the reason I'm mentioning is that every pilot who flies a plane and any airlines in the world actually gets certified on a simulator. And once you fly a simulator, you get a certificate that allows you to fly an aircraft. You may not know that, but talk to pilots who are flying, they all get trained. But there is nothing like that in the area of surgery, because robotic surgery is also a very complicated machine, but nothing is done. Perhaps a training simulator like this would become a standard so that you can compare every surgeon with another surgeon to know if you have a basic skill to drive. Sort of like getting the driver's license to drive a car. One very interesting concept that we brought in later on was to use an augmented reality idea, and actually we have 2 patents on this. The idea was that can you capture a good surgery? That is, a surgeon is very proficient, right? And I always like to say, if you watch somebody play golf or somebody play music instrument, a proficient person or someone is playing cricket, right? You see somebody hit the ball, it looks so easy. You go and take a bat, you'll never be able to hit like that. The reason is that watching someone do well and learning to do that is actually 2 different skills, right? So the idea here we were trying to do was, if the surgeon is performing, can you capture all the hand-eye coordination motion and put that into a simulator, and then have the trainee sit and watch the surgery, putting the head in stereo and hold the stool, and the stool will actually take you through the steps of doing anastomosis or fundamentals, so you're guided. And the closest example I can think of is a parent teaching a 2 or 3-year-old kid how to hold a pencil or a pen and trying to teach. Or a kid is learning how to ride a bicycle, and you have a tricycle, side wheels, and one day you take the wheel and the parent is holding the wheel, the cycle, and then you leave it, and one day you suddenly realize that you can buy it. Right? Can you do something similar to that? Right? So there are really great ideas to take the skill of a person and transfer it to a novice, and we actually did a study on anastomosis, and we compared training on a real plastic anastomosis, and we compared with a person who learned anastomosis using our technique called the course. And then we tested the leak of the object, the pressure, water pressure. And the study actually showed that the people who trained on the host group actually performed better than the people who learned to do anastomosis on a robot. So which means that even if you are given a $2 million robot, sometimes simulators are better to learn than the robot itself. Right? That was a surprising result that we got in the study. So now let me just continue talking. Dr. Robotic mentioned how robotic surgery doesn't have touch. This is again one area that my lab has worked extensively. We had a couple of students working on that. And so here what we're trying to do is use a 3D cloud. What 3D cloud does is that right now you have a stereoscopic camera that goes in endoscopic camera. What if you can get 3D cloud from that? If you can get 3D cloud, then we can actually get 3D surface render inside the organ while you're also looking at the organ. So what you see here is that this is not a real surgical robot. The robot which I'm seeing here is actually used for basically to research and things like that. And then once you have the point cloud, you can push and you can actually feel the organs. So by using this, you can also start giving sense of touch in robotic surgery. And one more very interesting thing that a student did was creating a boundary, what we call a forbidden zone. So you can mark on the computer where you don't want your tool to go. So for example, if you have a carotid vessel or something like that, you can mark in the computer, and then when you do the surgery, the tool will not cross the boundary. So there are a lot of interesting concepts that is coming forward that eventually will get integrated into commercial robots so that the robotic surgery can be safer in the future. So So this is basically the data collection system that we have been designing to see whether that can go inside the body like an endoscopic tool. Finally, let me just talk about, we heard about single port surgery, and we saw Da Vinci has one single port. You can put 3 tools inside. We've been looking at seeing if you can build a single port surgery which is much smaller, but also you can put multiple ports. Multiple, it's not 3, but we can put 4 or 5. So we actually have a patent pending technology on that, and I'll just show you the video. The idea is that it actually comes out to the same port, and then can come out and then expand, and then, so we can actually put 3 or 4 ports in the same space. So you can have cases where you need more than two different arms, you can easily put that as well. As you can see, this is a penny, which is small, and it's a very tiny little robot, and it's a fully articulated robot. And just to give you an idea of what kind of miniaturized robots that will come in the future. This again work done by one of my doctoral students. This video is from a conference that we presented in Germany last year. Finally, what are the opportunities? The opportunities really exist is in data. Why am I saying data? It's because in any mechanical system, there is lots and lots of sensors. A lot of data is being collected in real time. There's video data, there's robotic joint angle data, and many other data that we don't even know exist, because these are data that computer is collecting, right? Like for example, if you drive a modern car, say Toyota Innova. Toyota Innova picks up 425,000 data every second, which we don't even know about. Why we don't know? We don't need to know about it, right? Because we press, the car is moving, everything is working fine. But these data is going into this computer chip, this keeping the car going. That's how the modern technology works. Same thing that happens in robotic surgery is that these robots are collecting a lot of data. Is the data being used for anything? No. Most of the time it's used to make the system work properly. Data can give you wealth of information. Like, is the surgery going on well? Can you predict whether the surgery is moving towards success or a failure? So the future is really all about data. Some companies like Johnson & Johnson has a big project with Google. Their whole idea is to take this data. Every surgeon who does a case, they will upload the data into the cloud, and the cloud will be used to do a very large AI model, things like that. Well, it's not come to fruition, but the idea does exist. So that is a very interesting area. The concept of having a black box, that is put all this data into black box, and black box will tell you the information, like ChatGPT. You don't know what is happening in ChatGPT. You type in something and generative AI pulls out of anything, right? You don't know how it was designed, but this concept of generative AI is really a black box. So the black box can probably make surgery better, because if the data is there from 100 surgeons and you do not know what others are doing, maybe the system can tell you that maybe somebody else did this case in a different way, which was better. So there are a lot of exciting potential for future automation and technology that I might, like I told you earlier, all of you youngsters here, you're going to see it in your life. Okay? So I really, in some way, I envy all of you. Thank you.
Thank you. Thank you for the illuminating session, sir. Next up, we have Dr. Aishwarya Arjun, co-founder, ATRE Health Tech Private Limited, to deliver a talk on transformative power of telerobotics in healthcare.
Good afternoon. I was thinking when Dr. Murugesan first started his talk, how, 25 years ago when he used to pick on one of us in class and say, tomorrow you have to make a presentation, exactly what happened to me yesterday. He said, you have to come and talk to the students, which is why I happily agreed, to listen to all these very, very renowned speakers before me, and to let you know what we do here in Coimbatore is a real privilege. Good afternoon to all of you. Today, I'm speaking to you on a topic that's in the forefront of technology, innovation in healthcare, that's telerobotics. Let's begin by acknowledging that healthcare has been undergoing a paradigm shift in recent years. From a point in time in my growing years where dinner conversations were really, my dad, my grandfather used to talk about how they made a diagnosis when the patient was walking into their office. And today, Satya Nadella in one of his talks quotes that over 100,000 data points are considered before making a probable diagnosis with the digital technology in health. So I'm not here to say this is right or not, this is better than the other, but all I'm saying is it's time for us to embrace technology and use it to advance healthcare. I'm not going to go over my slides. I know we've taken a little more time than we planned to, and both Dr. Ramlingam, Dr. Murugesan, and of course Kesh did a wonderful job with telling us what robotics can do for us. Yeah, these are all the various applications. I'll quickly jump to the slide about what we do at R3. This is an overview of what we do. In this picture, the doctor sitting at the tertiary care center is operating a robot that's located remotely. When I say remotely, the robot can be in an emergency situation, in an ambulance, in a rural area, conducting mass cancer screening programs, doing home visits for old people with special needs. So it's a mobile device that can be on the move, and the doctor controls it, sitting at his office. Yeah, this is a detailed description of the features that the solution provides. The doctor can perform an ultrasound on a patient located remotely. The doctor manipulates a probe similar to the ultrasound probe. As you can see, what he's holding is very similar to the ultrasound probe. So the learning curve is minimized, and the image that he generates from the probe, the doctor sees in real time, and the doctor can change the settings of the ultrasound machine from his end. There's a two-way audio-video communication that allows the doctor to speak with the patient and vice versa. The ultrasound image, the robotic arm command, haptic feedback, and the video conferencing facilities are transmitted in real time through the internet. Of course, that's the patient end probe, which is attached to a single-arm robot where there's 6 degrees of freedom, and which allows the robot to mimic the doctor's hand movements. I'm happy to take questions, and of course, nothing comes without challenges, and we know now that from what Dr. Kesh told us about, that the research is still work in progress. But I think as doctors, our responsibility would be in securing privacy and for patient data. And I was quite happy to know that 2 days ago in the UK, there was an AI safety summit that was held, and this helped with establishing global standards around AI safety. And I think it's small steps like this that brings down standard operations world over and help in advancing robotics. I'd like to end by saying that these advancements that in artificial intelligence, of course 5G connectivity, improved haptic feedback, and other such advances are definitely going to be the way forward. And by integrating these features in our system, I'm sure telesurgery, or like Kesh showed us in his presentation, remote ultrasounds and features attached to that, in the sense that when you identify, let's say, a breast lump through your ultrasound, doing a tele biopsy won't be far from today. Yeah. So the task assigned to me was to remind you all that it's possible to do it here in Coimbatore, and with PSG Tech and all their support, I think it starts with an idea. Yeah.
Thank you for the informative discussion, ma'am. Our next speaker is Dr. Anand Narayanan, Consultant, Cardiothoracic Vascular Surgery, PSG Super Specialty Hospitals, upon the topic Robotic Cardiothoracic Surgeries, our institutional experience.
Good afternoon, everybody. I thank Coimbatore for giving me this excellent opportunity to present our institutional experience of robotic cardiac surgery. As we all know, the field of robotic cardiac surgery, the field of robotic surgery per se is expanding throughout the world. For all your information, robotic surgery first was introduced in cardiac field before even abdominal surgeries. Then it was somehow given up because the initial versions of robot were not that user friendly and it met with some accidents. So the concept of robotic cardiac surgery was given up, and it is greatly resurfacing again. And at present, say of 100% of cardiac surgical work, easily 10 to 15% of overall cardiac surgeries are done using surgical robots with reproducible results, and patients are getting benefited in a great way. So I believe this talk will be quite interesting for youngsters, basically medical students, who can get inspired by what is happening in our institute as well. I am going to talk only about the cardiac part of the robotic services what we offer here. Other than this, our institution is fastly emerging as the robotic surgical center in this city of Coimbatore, and we are going to make some big changes in the state as well. So, traditionally, heart surgery was done by opening the sternum, because for you to reach the heart, you have to break the sternal bone, and then only you can go into the pericardium and operate. So on a routine day, intraoperative field inside or in a routine cardiac surgery operation theater will be like this. It will be completely open. The chest bone is widely open. You can see all structures of the heart, all parts of the heart, and they are all nicely accessible, and we can, and almost all types of cardiac diseases were cured by this standard sterotomy approach. This has been the gold standard for long time. It gives excellent exposure. Almost all types of pathologies can be corrected. It has stood the test of time, and the learning curve is quite small in the routine standard steroid approach. It has also got some reasonable amount of disadvantages. The most common disadvantages is that it incurs significant blood loss. As we all know that any type of open cardiac surgery will entail at least 2 to 3 units of blood transfusion. Cosmetically, it is not that appealing for the majority of patients, mainly females. And the recovery time, as we know, is somewhere around 6 to 8 weeks. As we say that more, it's like a fracture. Any fracture as we incur, we know that we have to wait for us to resume work for at least 4 to 6 weeks. In cardiac surgery, it's around 6 to 8 weeks. The pain is definitely there in the standard steroid approach. But the most dreaded complication in a steroid approach is the sternal wound dehiscence, wherein old patients, diabetic patients who don't have their sugar control properly, they tend to develop sternal wound infection. This is a surgeon's nightmare. More than the surgeon's nightmare, it's the patient's nightmare as well, because once the patient develops a sternal wound infection, it takes a long time to recover. They stay in the hospital for at least 4 to 5 weeks, and their road to recovery takes at least 3 months for them to get back to their work. So keeping this in mind, to reduce the number of infections and the to reduce the blood transfusion, the surgical society moved towards direct vision minimal access cardiac surgery. And as an evaluation, we have moved from that point onwards to robotic cardiac surgery in the current day. So the philosophy of minimally invasive cardiac surgery has been focused exposure. As we saw in the first slide, in the traditional sternotomy approach, even if you want to operate only the mitral valve, you will be accessing the whole heart. You will be accessing the left-sided full surfaces, left up, even the left ventricular apex and the whole stuff. Whereas in a minimal access approach, you will see only the heart. You will expose the body only to that much extent so that you will visualize the mitral valve exactly where it is. Say we expose the chest through the fourth intercostal space for the mitral valve, and if you want to work on the aortic valve, you come on to the second intercostal space. Supposing you want to do a CABG, you go on to the left side of the patient and you do a thoracotomy somewhere around the fourth or fifth intercostal space, and you see exactly the left anterior descending coronary artery and do the CABG and come out. So this gives the advantage of a smaller incision, and it also negates the need for sternotomy. And whenever we need the patient to be connected to a cardiopulmonary bypass machine, we use femoral access, and this gives an excellent control for cardiopulmonary bypass as well. So we attain all the things what we need to attain in the standard sternotomy approach through minimally invasive approach as well. And this was the first step for us to move towards the robotic cardiac surgery. For the prerequisites were you need to understand the pathology, what you are dealing with in a correct way. You cannot afford to have intraoperative surprises, say like you going for reading the mitral valve, and on table you find out that the aortic valve is also involved. That is a big catastrophe, and you might need to do a conversion sternotomy to complete the procedure. Assessing the patient habitus is quite important. On date, robotic cardiac surgery is not so suitable for morbidly obese patients and very, very frail patients as well. So the patient habitus also plays a role in what type of surgery or the success quotient of the robotic cardiac surgery. Meticulous planning is involved and all the availability of equipment. So minimally invasive robotic cardiac surgery, it's a minimally invasive technique which is used to treat patients with some form of heart diseases. It is considered to be more efficient than human hands because the main disadvantage of direct vision minimal access cardiac surgery is that you will be seeing something only through a telescope, like a tunnel vision. Because of that, the length of the instrument what you need was quite long, and as you know that if you hold a long stick in your hand, because the tremor what you have in your hand is magnified at the end of the stick, and the stick it shakes a lot. And that was a bad disadvantage in direct access, direct vision minimal access cardiac surgery, which is completely negated by the robot. So it removes it filters the tremor and it gives an unshakable movement at the end organs. As we all know, and it has been shown clearly, the robot is externally controlled by an experienced surgeon who guides the robotic hands to perform surgical actions. Robotic surgery for heart ailment is conducted with the help of a surgical robot, as we all know. Apart from cardiac surgical procedures, other procedures are also done in India, such as urology, orthopedics, pediatric, and gynecology. On any robotic cardiac surgical operation, theatre will be like this. As we can see, that the two orange rings are the surgeons. One surgeon will be sitting far away from the patient, and he will be commanding the robot to make all the actions. And the second surgeon, who is standing next to the patient, will make sure things are proper, and he will be there to troubleshoot any problem which the operating surgeon has. To give you a small overview, the audio is not working. You can just have a look at the video. As we can see, that these are ports through which the robot operates, and these are the instruments which the surgeon commands to perform the operation. This is how the surgeon places himself at the console, and his movement will be transmitted as actions in the robotic arm. This is where he places his eyes to have a clear 3D vision of the intraoperative field, and whatever movement he makes through his wrists will be transmitted there at the robot, and this robot will perform all the necessary surgical steps. What is so exciting about robotic cardiac surgery is the amount of exposure and the magnification of tissues, what we get out of the target tissue, what you get out of surgical robot is absolutely amazing. I will show some more comparative videos of open and minimally invasive or robotic videos shortly. This is how it works. He makes movements through the joystick, which is attached to the patient console, and those actions are transmitted like this. He removes the tumor from the abdominal wall, and the surgery is completed without any blood loss and a very, very limited scar. So, what takes one to become a robotic surgeon? It involves excellent commitment from the robotic surgeon. You cannot just become a robotic surgeon on the next day of your surgical practice. You need to undergo at least 6 months of training at a specialized center. Thankfully, in the current day, there are a lot of training places. Even in the robot itself, they have a lot of simulations wherein you can get trained by yourself before moving on to the patient side. And there are mannequins in which you can practice suturing or dissection at a laboratory that before making a move onto the patient's tissue. Because once you are on a patient tissue, there is no margin of error, and specifically in cardiac surgery, every mistake is counted on the patient's life. So, just as a comparative video, I will show what is how open surgery look like. See, in this surgery, the surgeon is operating in a standard sternotomy approach. He is operating on mitral valve. As you can see, that is the amount of exposure what you get out of the open surgery. It's quite fast. He's inspecting the part of the anterior mitral leaflet, as all undergraduates know. Mitral leaflet has 2 leaflets. He is seeing what is the problem in the mitral valve leaflet, and he is adjusting and planning his surgical techniques. So only this much of a magnification you get in a traditional open heart surgery, because as you know that left atrium is quite a posterior structure. It's very, very close to the vertebra, and the exposure is good, and it is easier only for a very, very experienced surgeon. For a novice surgeon to start with complex mitral valve repairs, it's quite tough. I'll just show our experience. This is mitral valve replacement which we did in our hospital. Just to show you what amount of exposure what we get out of the surgical robot. This is a short 2-minute video wherein you can see the magnification what we get out of a surgical robot which makes our job quite easier and interesting. The amount of magnification what we get in the surgical robot, it is as though we are standing inside the left atrium and removing the apparatus. I mean, we saw the previous slide wherein the surgeon was having almost a 15-20 centimeter distance from the eyes of the patient to the mitral valve apparatus. It's quite tough. This exposure is unmatched, and the precision which the robot performs, the manipulation what the surgeon does, and which is exactly being transmitted to the patient head is really unmatchable from the surgical robot, and it is very interesting. This is mitral valve replacement what we did. And the patient recovered quite well. He was discharged in just 4 post-operative days. This is the first robotic intracardiac surgery what we did. This is a case of left atrial myxoma, huge tumor inside one's left atrium. This small boy, 17-year-old, he has just got his admission into an engineering college at Bangalore. And before he could join college, he developed severe breathlessness, and he reported to a peripheral hospital at Kollachi, where he was diagnosed with a huge left atrial myxoma, and we operated on him. So this is how it works, where I am working on the console, my movements are transmitted via the surgical robot inside the patient, and we could successfully remove the big chunk of tumor from inside his left atrium, and he recovered well. The exciting point is that he could join his college in just 15 days, and he is currently in functional class 1, riding bicycles from his home to college, and the whole family is quite happy about the speed of recovery that we have. My dear students, this is happening just under your nose in your institution. Not only this, we are doing a lot of innovative surgeries in cancer as well as urology, pediatric surgery. Madam is doing a fantastic job here. So you all should get inspiration out of this, and it is you who should take this to the next level. Our experience is quite limited. As of now, we have done only 6 intracardiac surgeries. 2 were mitral valves, 2 were myxomas, and 2 were congenital. As I had a unique opportunity of getting trained in both adult and congenital, we did 2 congenital robotic heart surgeries, which is one of the first in the country and probably one of the first in world literature. We recently operated a partial AV canal defect through a surgical robot. So what I want to say is that the possibilities are really infinite. It is for us, it is up to us to utilize what is available and just hard work and improve, or just keep erasing the horizons and setting up new horizons. With this, I thank you, thanks sir for giving me this opportunity, and I believe the future is going to be interesting. Thank you very much.
Thank you for the enlightening discussion, sir. We have reached the end of such an outstanding interactive session on robotics and research. On behalf of PSG IMSR and super specialty hospitals, we would like to extend our gratitude to all the invited speakers, faculties, and dignitaries for gracing this occasion and making it an eventful one. Thank you. I would like to call upon Dr. P.R. Murugesan, Professor and Head, Department of CTBS, to conclude the event by delivering vote of thanks.
Once again, good afternoon, good evening. We spent 5 minutes to just go through it. There are senior consultants, and we just have some clarification with Dr. Kesava and Dr. Ramanigam and the other faculties here. Officially, I want to quote something which is very essential for our program. Dr. K.S. Rajkumar, who is a senior consultant, surgical oncologist, is linked to the robotics. The program is going in PSI in a very big way because of his backbone effect. And second, Dr. Saravanan Rajamanikam, who is a surgical oncologist once again, keen to do thoracic work, and he is a thoracoscopic and robotic surgeon. He is helping us all the way through this hardship of venturing into the cardiac robotic procedure. And Dr. Pao is here, and he is taken the effort to perform in pediatric procedure and lot of procedure on gynecology, urology, and other general GA surgery. On behalf of the whole robotic team of our institution, I thank the management. They have established a very big ground stability to continue this with affordable cost. Now probably Dr. Ramani will lead the queries, which is probably you want to just ask and clarify. And definitely the iRobot is going to be the future Coimbatore product. We will probably do some associate research work to make something affordable, the theme of the vision of Make in India. Thank you. And Dr. Ganesh is here. He is probably the person behind the scene to make the robotics more comfortable and more feasible for us as a surgeon. Because, see, Dr. Ananda has mentioned so many things, but it's actually a fearful venture entering into a robo in especially cardiac surgery. It's not like laparoscopy somewhere. Here we need to control the heart throughout the procedure. If I am doing a valve procedure with sternoctomy, it's hardly 1.5 to 2 hours. Here it's going to 6 hours. The heart will be quiet for 6 hours, or at least 4 hours. How would you make the heart quiet for 4 hours? Then you have to awake and you have to breathe in silence, so you have to pump properly. If you lost that moment, then you are losing the patient. So it's not like any other surgery where you just put the robot, anastomose thing. If it's not working well, you open an anastomose the bowel or resect the liver. It's not so. The heart should be quiet for many hours without any insult to the myocardium. That's a big concern. He told the first steps of the initial things failed, they are not keen of doing it. Everything because of inadequate myocardial protection and problem with getting back the heart to beating and pumping flow. So that's a big concern. The head and anesthesia is really a kind of a big support for us to get the heart back. Either you do a full opening, mini opening, or any opening, the heart should be back and they should go home. So that's the concern with us, and our anesthesia team led with Dr. Ganeshan is having great support and enthusiasm. If the anesthesia say, why not just conventional finish in 3 hours, go home, then no program on heart will never exist. And at another level, once again, I have to congratulate and wish you for a better progress in this, because I am not too old, same time not too young. I experienced over 25 years of cardiac surgery very hard way. Single surgeon, open the chest, open the leg, take the vein, anastomose. What I am doing, that's the surgery. And Ganesh will be observing from the head. No other person should know what is happening. I repair the wall, I know how much I repaired the wall. There is no DE also. The patient comes back to me after 6 years, 1 year, some of the wall I now replaced. So that's the freedom we had 25 years back. Today we have a TEE, you can't miss the repair because everybody will know that this not repair. So that's 25 years back. Now probably this generation of surgeon and the young student to take all this advanced technology into the practice, that we can make great advancement in healthcare system of India. Thank you. Now probably Dr.Kesava is here to clarify some of the doubts for another 5 minutes. Thank you. Thank you, one and all. Thank you.
Thank you, Mukesh, for running the whole show. I have a very practical question and a very theoretical question to Dr. Kesh. Kesh, the single port flexible robot is so very expensive. You have already designed one. When is it going to be available and how much will be the cost? So in pediatric and maybe for cardiology, they can go through one hole and then finish it instead of having multiple holes. And when will you enjoy that your machine? Yeah, I'm asking you, your flexible instrument, when will it be available for practical use?
So right now it is still like a student project. So to take any technology in the medical, the problem is the lead time. Taking idea from lab because it has go through so many steps. So for that to be fully successful, it'll take another 3-4 years before it'll come out. But you know, the patents have been filed, and the manufacturing is very difficult as well because we did 3D metal printing for getting the shape of that. So you know, we'd find more easier way to manufacture.
Thank you. At least in 3 years it will be available. It's a happy note. Then one theoretical question. We have two researchers here. One is Raghuram in AI. He is an AI guy was in US, and Dr. Arun, who is a robotic guy from Wales University. They will also have some questions to answer. Before that, you are so much interested in the AI. And when this AI will help us to make our surgery easier, maybe to warn us, you are very close to the first branch of the kidney artery, or you are very close to duodenum. When will we get that benefit?
You know, the technology is itself is not very far off. Like I mentioned, like J&J, Johnson & Johnson robot they were designing, they were trying to completely integrate a pre-done 3D scan with the surgery. So in principle, like there are, you know, like in the spinal surgery I showed you, they merge the 3D image on the spot, so they can exactly map the 3D image where the patient is. If they can exactly match it, they can actually give you some 3D estimation already, right? But using images itself, you know, like looking at machine learning and looking at various images, I think that some kind of predictive analytics can be done already. But now to put that in a clinical, in a robot, I think is the challenging part, because most of the AI systems are not ready to be approved by FDA. It doesn't mean FDA is not approving it. There are some products FDA has approved, like for eye, there are some FDA approved AI solutions already, but I think that they're very, very slow. They still don't know how to validate whether AI is correct or not. And that is a challenge. I think they will take another couple of years, but they are looking at you know, coming up with a new process of approving AI solution for not just surgery, but many other medical applications.
So these benefits will we'll have to wait for the big data to be pooled further into bigger data?
Yes. And then someone has to go to you know, FDA and prove that what they are showing, because like everybody knows ChatGPT, right? When you type something, it gives you the answer. Sometimes it does hallucinations, sometimes it gives you fake data, which a human being can make out. But if it starts doing the same thing in surgery or in medicine, how can you be sure, right? So there is still a lot of work to be done before government will say that, okay, now this is mainstream, you can completely trust AI, right? So I think that in the next couple of years, because there's a lot of different study groups, National Institute of Health has a study group, FDA has a study group, they're all looking at how can we validate and say.
Is it an animal study or real time?
Even without animal study, can you approve AI without X number of patients, or what do the companies have to show that my data is reliable, right? There is really today no standards.
Raghuram, have anything to? Yeah, Pavai?
Miniature. You know, the problem is that most of the big companies, they're not investing in small tools, right? It has to be done, but I know that yesterday I was seeing a...
No, CMR has got a 5mm tools.
Yeah, but they are talking about even smaller than 5mm, right? 5mm,
5mm is the one the CMR has got.
CMR has 5mm.
The other thing, companies have 8mm. 8mm.
See, I do not know if 5 is small or not. Is 5 small enough?
The CMR company told us that the 5mm instruments are not as stable as your 8mm instruments, and actually we would prefer even a 3mm. That's what we usually use in laparoscopy, 5 and 3.
Yes, sir, I'm wondering. I just saw yesterday, I forgot to get the name, a Korean company which is doing a smaller, much more like 3mm or something like that. Maybe if you search in Google, you can see. It's like a news, I saw like 3-4 days back. I wanted to put it in the presentation, but I lost it, so I can go and search for it again.
I have a question.
Yeah.
So can you tell me more about that transformer thing you were talking about?
Yeah.
Like for the multispectral images. So you said.
So transformer is it's an AI technique.
Yeah, I am aware of that.
Yeah. So if you want more, I can send you a paper. I think maybe it's not in 30 seconds.
Okay. So it's done by your work.
Yeah, my group. Yeah.
Okay.
If I can get my email, I'll give you my card.
Sure.
I can send you a paper that it's not published yet, but we just submitted it.
Okay. Sure.
As a teacher, we were interested in simulators. Early laparoscopy, we could make a big change because of the cheaper simulators, which Ramalingam was training so many people across the country as well as outside.
Yeah.
No problem, sit up. So in robotic surgery, can we get cheaper simulators to train ourselves, to train our students?
Well, I think that the simulators are very expensive now, but I think there is a team here who's also looking at making something which is more affordable, and there's no reason why it cannot be done, right? Like anything which first comes in the market, they are more expensive. But finally, if you take out all the unwanted thing and compress it, if you look at basics, what is needed for learning, I think the cost can come down. Right, in laparoscopic, 2 camera and a box, right? But in robotics, you can't do that. That's simply.
Faisal, can you stand up? We have people from US, Kesh and Faisal of surgical simulators who have done the first surgical simulator RAS 1, now it is RAS 2. And along with Dr. Aishwarya's team, Arjun, and can you stand up, Amrita? We are all trying to bring it to our country as RAS India. And we have to be grateful to Dr. Kesh to give all the design, everything. He is so grateful. And I think in a year or so, your question will be answered. You will have a hands-on with, for your students, you can train them. He is a great teacher who taught us surgical procedures. Now he is a colleague of mine. He is with our team.
So that's great. I was in the Indian Cancer Congress meeting yesterday in Mumbai, and I was in a session for technology for oncology, and this exactly the same topic was discussed about why there is only 120 robots in India, right? Compared to in US, there are 8,000 robots. When the population of India, US is only 300 million. So, upskilling and people, and I think I'm still here, I think Dr. Somashekhar, I'll check the name.
Somashekhar.
He was saying that he runs a training program in Manipal. Out of 10 people who come for training, only one stick on to robotics, other 9 drop out. And so he was saying the training is very challenging. And that's what Faisal and Aisha, they're all trying to do is, and I mentioned that there's a team trying to make it affordable because I believe that simulator is the first step that will make someone confident. The reason why people drop out is they go and do a case or maybe even a pig and they come out saying it's very, maybe I'll go back and do my laparoscopic surgery or whatever. But if you can do it in a simulator, like, kids play flight simulators, and in one day they can fly a plane, right? So why not get confidence first? Then you'll see more people converting to robotic surgery.
You exactly answered my question. What Dr. Ramamurthy, he came for 1 month. Every day, 1 hour between 12 to 1, he is there on the console. I was trying to guide him. I will not say teaching. He's a teacher. Guiding how to take sutures, dissecting the oranges, grapes. Religiously, he came for 1 month. Now he is not coming in the last 1 month or so. So if you probably have a simulator, easily available, you are not causing any big problem, then it will probably stimulate better.
Yeah, gamified, like gaming, right? If you have gamified and approach is more, like a fun, you're learning skill while you're doing that. That's what simulator does.
Yeah, the master problem is over, no? Master control is over. Then all that you need to be is to be identify the structures and pathology.
I will tell you my own experience. While I was developing the robot, the ROS, I played out it so many times. I have gone and tried to do anastomosis. People think I'm a surgeon. It's simply because it's a skill. At the end of the day, I have no idea if I put in a patient and kill him in 2 minutes. But basic skill, hand-eye skill, I have very good skill because of my own simulator system, right? So yes, can the skill be learned? It can be learned in a simulator. Then of course, what surgery is doing is what you learned for 15 years.
Exactly.
Right.
So it will happen in 1 year in Coimbatore with PhD group. So it's a good news for all of you. Thank you, everyone.
Thank you very much. Probably we'll have an official photograph. It's a kind of a day. It may not happen in the near future. Just we'll assemble here and we'll take one photo. Aisha and other people. Prakash, come. Prakash is our theatre in charge staff, the man behind the robotic arm. Come, Prakash. And Imran is our perfusionist. They need special skill and dedication to conduct robotic surgery assisting. Please come. We'll take one photograph.